Treatment of multidrug resistant organisms, Part 2. We left off from last time talking about the treatment of pyelonephritis and complicated UTI caused by CRE. Treatment recommendations includes all three of the previously discussed antibiotic beta-lactamase inhibitor combinations. In addition to those three antibiotics, new drugs have been added as alternatives: Cefiderocol, Plazomicin, and also once-a-day aminoglycosides. Cefiderocol, or Fetroja, was approved in November of 2019. It's a cephalosporin that's similar in structure to cefepime, and it has an important catechol side group called a tosylate. It is what's called a siderophore. The catechol side chain forms a chelated complex with iron, which is then actively transported into the bacterial cell via iron receptors. It therefore gains entry into the bacterial cell wall via a Trojan horse strategy. The cephalosporin is then released, attaching to the penicillin-binding proteins and thus inhibiting cell wall synthesis. We need to reduce the dose of this drug if the creatinine clearance is less than 60 mL per minute, or we need to increase the dose if the creatinine clearance is greater than 120. The cost of 1 gram is $183, which is about $1,000 per day. The dose of Cefiderocol is 2 grams every 8 hours by IV infusion. Each dose is given over 3 hours. It's available as 1 gram vials that are refrigerated. The FDA-approved indications are complicated urinary tract infections, including pyelonephritis. It also has an indication for hospital-acquired bacterial pneumonia and ventilator-associated bacterial pneumonia caused by Acinetobacter, E. coli, Enterobacter cloacae, Klebsiella pneumonia, Pseudomonas aeruginosa, and Serratia. It primarily has a gram-negative spectrum, including Pseudomonas, but no activity against gram-positives or anaerobes. One interesting point about the drug is that its clinical studies showed that it had a 28-day all-cause mortality in patients with carbapenem-resistant gram-negative bacterial infections. The drug showed a 28-day all-cause mortality rate of 24.8% versus 18.4% when treated for pneumonia, sepsis, and bacteremia. However, a subsequent study looking at the indication for hospital-acquired pneumonia and ventilator-associated pneumonia showed no difference in the 28-day mortality, 22% versus 21.1%. It seems to work best against Pseudomonas and not as good against Acinetobacter. Plazomicin, or Zemdry, was approved in June of 2018. It's a semisynthetic aminoglycoside that's derived from cystomycin. Since it's an aminoglycoside, we need to adjust it for renal insufficiency. As with aminoglycosides, there's a black box warning for nephrotoxicity. It has the ability to cause renal dysfunction in 3.6% of patients versus 1.3% of patients on a comparator meropenem. Serum creatinine increases of greater than 0.5 milligram per deciliter above the baseline occurred in 7% of patients versus 4% of its competitor. Ototoxicity can also occur, manifested as hearing loss, tinnitus, and or vertigo. The cost is about $600 per day. The dose of plazomicin is 15 milligram per kilogram every 24 hours by piggyback over 30 minutes. It comes in a 10 ml vial and it needs to be refrigerated. It's FDA approved for complicated urinary tract infections, including pyelonephritis, and it has variable activity against Pseudomonas aeruginosa, but some in vitro activity against MRSA, ESBL, and KPC. For uncomplicated cystitis caused by CRE, we can use conventional oral agents like nitrofurantoin, ciprofloxacin, levofloxacin, or trimethoprim sulfamethoxazole. Multidrug-resistant Pseudomonas aeruginosa. Pseudomonas aeruginosa has been called the grand old man of resistant nosocomial pathogens. because concerns of resistance have been associated with it for many years. It's best known for developing resistance against fluoroquinolones. The impact of multidrug-resistant Pseudomonas is estimated at over 32,000 cases and 2,700 deaths in the United States per year. Pseudomonas aeruginosa infections usually occur in people in the hospital with weakened immune systems. It's particularly dangerous for patients with chronic lung diseases. Due to extreme resistance to most antibiotics, extremely drug-resistant Pseudomonas infections need to be treated with combinations of current antibiotics and beta-lactamase inhibitors. For serious infections occurring outside of the urinary tract, Ceftolozane-tazobactam is the drug of choice for extremely drug-resistant Pseudomonas aeruginosa. Even though ceftazidime-avibactam and imipenem-cilastatin-relebactam can be used, Ceftolozane-tazobactam is the preferred agent since the percent clinical isolates sensitive to the drug is higher than the others. Ceftolozane by itself owns activity against Pseudomonas. Ceftolozane-tazobactam, or Zerbaxa, was approved in December of 2014. The tazobactam portion is the beta-lactamase inhibitor. The dose is 1.5 grams every 8 hours over 1 hour. The dose is twice as much for hospital-acquired pneumonia or ventilator-associated pneumonia, 3 grams every 8 hours over 1 hour. The drug is available as a 1.5 gram vial with ceftolozane 1 gram and tazobactam 0.5 grams. The vials are stored in the refrigerator. FDA-approved indications include intra-abdominal infections with metronidazole, complicated urinary tract infections, pyelonephritis, and hospital-acquired pneumonia and ventilator-associated pneumonia. You need to adjust the dose for renal insufficiency, and the cost is about $340 a day and twice as much for hospital-acquired pneumonia, ventilator-associated pneumonia, about $700 per day. For pyelonephritis and complicated urinary tract infections and uncomplicated cystitis, ceftolozane-tazobactam is the drug of choice. As alternatives, ceftazidime-avibactam, imipenem-cilastatin-relebactam, and Cefiderocol are available for use. Carbapenem-resistant Acinetobacter. Treatment options for infections caused by carbapenem-resistant Acinetobacter are extremely limited. You can see in the table how resistant the organism is. Any fluoroquinolone is 89% resistant, and any extended spectrum beta-lactam is 75% resistant. So you can see how difficult it is to find a drug that is effective against Acinetobacter. For serious infections of highly resistant Acinetobacter, the options are very few. Tetracyclines can be used, tigecycline at high doses can be used, minocycline as well as eravacycline. Sulbactam at very high doses of 2 grams every 6 to 8 hours can also be used, and Colistin can be considered as a last-line agent. Colistin comes from the polymyxin class of antibiotics, polymyxin E. It's been available since 1960. Colistin is administered as an inactive prodrug, colistimethate, or CMS. CMS is converted to colistin in vivo. The active drug is called colistin-based activity, or CBA. About 25% of this conversion is dependent on renal function due to tubular secretion and can vary with renal insufficiency. For colistin, it's important to note that the dose is always based on the CBA, or colistin-based activity. The chart at the bottom of the slide shows the differences between CBA and CMS in both milligram amounts and international units. We start off by giving a loading dose of 4 milligrams per kilogram. Use the lower of the actual or ideal body weight, and start the maintenance dose 12 hours later. A maintenance dose of 300 milligrams per day in divided doses should be given, with a maximal daily dose of 300 milligrams. Adjust the dose for renal insufficiency. Adjunctive inhalation therapy for pneumonia can be given at a dose of 50 to 75 milligrams of the colistin-based activity CBA in 3 to 4 mL of saline twice a day or 3 times a day. Colistin has prominent nephrotoxicity, about 25%, and significant neurotoxicity. It is also concentration dependent with its killing. How can we as pharmacists help reduce the development of multidrug resistant organisms? By applying antimicrobial stewardship principles, we can improve appropriate use of antibiotics, reduce unnecessary use of antibiotics and duplication, apply de-escalation efforts to avoid prolonged duration of antibiotics, and collect, track, and share data to measure improvements and identify areas of need. There are 3 new antibiotics on the horizon that are in development and designed to treat primarily gram-negative multidrug resistant organisms. All 3 are combination drugs with beta-lactamase inhibitors. They are cefepime-taniborbactam, sulbactam-durlobactam, and aztreonam-avibactam. Surprise! It's quiz time! I'll be asking a dozen questions on the material that we've covered so far. It'll be a good gauge to see how well you retain the information. After the question, I'll leave a gap of time so you can think of the answer. Place the video on hold if you need more time. Okay, here we go. Question number 1. What is the best antibiotic to treat a documented ESBL Enterobacteriaceae infection? A. Quinolone, B. Carbapenem, C. Tetracycline, or D. Cephalosporin? The answer is B. Carbapenem. Question number 2. What is the best antibiotic to treat a documented CRE infection that is producing the KPC enzyme? A. Ceftazane-tazobactam, Avicaz, B. Meropenem-vapobactam, Vabomere, C. Imipenem-cilastatin-relebactam, Ricarbrio, or D. Ceftolozane-tazobactam, Zerbaxa? The answer is A. Ceftazane-avibactam, or Avicaz. Question number 3. What is the best antibiotic to treat an extremely drug-resistant infection caused by Pseudomonas aeruginosa? A. Ceftazane-avibactam, B. Meropenem-vapobactam, C. Imipenem-cilastatin-relebactam, or D. Ceftolozane-tazobactam? The answer is D. Ceftolozane-tazobactam, or Zerbaxa. Question number 4. Expanded spectrum tetracyclines like eravacycline may have a role in treating extremely drug-resistant infections caused by Acinetobacter. A. True, B. False? The answer is A. True. Question number 5. The most common mechanism of resistance that bacteria use against antibiotics is A. Efflux pump, B. Altered targets, C. Decreased uptake at the cell wall, D. Enzyme inactivation? The answer is D. Enzyme inactivation. Question number 6. When uncontrolled, multidrug resistant bacteria can easily spread from one healthcare facility to another. A. True, B. False? The answer is A. True. Question number 7. Uncomplicated ESBL-E urinary tract infections are best treated with A. Ciprofloxacin, B. Fosfomycin, C. Nitrofurantoin, or D. Doxycycline? The answer is C, nitrofurantoin. Question number 8. Which antibiotic is required to be administered over 3 hours? A. Ceftazane-tazobactam, B. Meropenem-vapobactam, C. Imipenem-cilastatin-relebactam, or D. Ceftolozane-tazobactam. The answer is B. Meropenem-vapobactam or Vabomere. Question number 9. Which antibiotic should not be given with valproic acid or divalproex, Depakote? A. Ceftazane-avibactam, B. Meropenem-vapobactam, C. Imipenem-cilastatin-relebactam, or D. B and C. The answer is D. B and C. Question number 10. Plazomicin is what class of antibiotic? A. Quinolone, B. cephalosporin, C. aminoglycoside, or D. tetracycline. The answer is C. aminoglycoside. Question number 11. The antibiotic that gains entry into the cell via a Trojan horse strategy is A. Imipenem-cilastatin-relebactam, B. Cefiderocol, C. Plazomicin, or D. eravacycline. The answer is B. Cefiderocol. Question number 12. Colistin is associated with prominent A. neurotoxicity, B. nephrotoxicity, C. hepatotoxicity, or D. A and B. The answer is D. A and B. How well did you do? I hope that this was a good summary of this topic. We've got a lot in store at the Farm Easy Tutor channel. There'll be upcoming talks on cold blue emergencies, management of acute heart failure, electrolyte management, quinolone side effects, and much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the Farm Easy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the Farm Easy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.